Imagine visiting like 5 different doctors over 4 agonizing years.
Yeah, just desperate for answers.
Exactly. Dealing with a pain so debilitating you can barely leave your house, only to finally get handed a referral to a psychiatrist.
Which is just devastating for the patient.
It really is.
Uh,
So today we are opening the medical files on a physical condition so elusive it frequently convinces doctors that the patient is entirely imagining it. Welcome to the deep dive.
And we have a really fascinating stack of sources in front of us today to get into this.
We do. We're looking at clinical guidelines from the American Urological Association, reports from the Royal College of Obstetricians and Gynecologists, some historical urology journals, and joint international terminology reports.
It is a lot of ground to cover.
But our mission today isn't just to understand a single disease. By tracing the medical history, the baffling biology, and the modern treatments of a chronic mystery known as interstitial cystitis, which is now increasingly called bladder pain syndrome, or BPS, we're going to explore something bigger.
Right, how chronic pain physically reshapes the human brain.
Yes, and how modern medicine tries to fix a biological machine when it doesn't even know what broke in the first place.
It's a huge topic.
It is. And even if you don't have this condition, this deep dive is an absolute masterclass in how medicine evolves. So, okay, let's unpack this. We have a condition that affects hundreds of thousands of people.
Oh, absolutely. Estimates show up to 400,000 sufferers in the UK alone,
Wow.
and well over 700,000 in the US. And women make up about 90% of those diagnosed, usually in their 5th or 6th decade of life.
That is a staggering amount of people suffering.
It is. And the sheer scale of that suffering is even crazier when you look at the historical timeline. Because, when a disease keeps changing its name across the centuries, it tells you the medical community is fundamentally struggling to grasp its nature.
Like they're just guessing.
Basically, yeah. I mean, going back to the historical urology journals in our sources, we see a physician named Joseph Parrish in 1836 trying to categorize this.
Right.
And he didn't call it a bladder infection. He actually described it as tic douloureux of the bladder.
Which is such a bizarre phrase for a pelvic condition. I mean, tic douloureux is French for painful tick, right?
Exactly.
And it's a term usually reserved for trigeminal neuralgia, that really severe spasmodic facial nerve pain. It sounds like Parrish was looking at the bladder but seeing a neurological misfire.
He was. He was recognizing that the character of the pain felt neuropathic, like a severe electrical misfiring of the nerves, rather than just a standard organ issue.
Which is kind of brilliant for 1836.
Right. But as medicine moved into the 20th century, the focus shifted away from the nervous system entirely. They zeroed in exclusively on the visible tissue.
Ah, okay.
So in 1907, a doctor named Nitze labeled it cystitis parenchymatosa.
A bit of a mouthful.
Yeah. And then in 1914, a physician named Guy Hunter popularized a term that would sort of dominate the field for decades. He called it the elusive ulcer.
Wait, we still talk about those today, right? The sources call them Hunter's lesions.
Yes, exactly.
They're these distinct inflammatory wounds that actually rupture the bladder lining. But, okay, here is the massive trap hidden in that history. Those lesions only show up in about 10% of severe cases.
Which is a huge problem.
Right. That means for decades, doctors were hunting for this elusive ulcer and completely dismissing the 90% of patients who didn't have one. They were literally telling them there was nothing physically wrong.
And that historical blind spot created a huge legacy of medical gaslighting. And then the terminology itself became the next trap.
How so?
Well, the medical community eventually settled on the name interstitial cystitis. And the suffix itis in medicine dictates how doctors respond.
It's like appendicitis or tonsillitis.
Exactly. It implies acute inflammation,
Yeah.
almost always driven by an infection. So cystitis quite literally translates in clinical practice to a bacterial urinary tract infection.
Okay, wait, I have to challenge this assumption. If the defining characteristic of this condition is that the urine cultures are completely negative, meaning there is zero bacteria, why did doctors assume it was an infection for a century?
It's a great question.
Like, were they just lazy, or is there something about the tissue damage that perfectly mimics a bacterial attack under a microscope?
It's more the latter. You see, early diagnostics were heavily reliant on seeing white blood cells and severe redness in the urine and tissue.
Right.
And to a 20th century doctor, white blood cells pouring into an organ meant one thing. The body was fighting an invader. They couldn't easily conceptualize sterile inflammation in the bladder.
Ah, I see.
So they would see a patient suffering from intense urgency, frequency, and pelvic pain and just assume it was a stubborn infection hiding in the tissue. And then they'd prescribe endless trials of heavy antibiotics.
And when those antibiotics inevitably failed and the cultures repeatedly came back clear, the doctors just threw their hands up. They said, well, the tests are negative, so this must be a psychological issue.
Which brings us right back to the psychiatrist referral.
Exactly. They completely missed the actual mechanism. It's like trying to fix a car engine when the mechanics keep renaming the broken part based on the strange sound it makes, rather than what it actually does.
That is a perfect analogy.
So if we know it isn't bacteria, let's dive into what is actually happening chemically and structurally. What is triggering this massive immune response?
Well, the leading pathophysiological theory detailed in the sources brings us to the very lining of the bladder wall. Because the bladder isn't just a simple muscular balloon.
Right, it's more complex than that.
Much more. It relies on a highly specialized protective barrier called the glycosaminoglycan layer, or the JAG layer for short.
Okay, the JAG layer.
Yeah. Glycosaminoglycans are essentially long chains of sugar molecules that are incredibly hydrophilic, meaning they attract and trap water.
Oh, interesting.
So this creates a thick microscopic moat of mucin that coats the transitional cells of a bladder wall.
So it's essentially the nonstick coating of the bladder. It's there to ensure that whatever toxic waste the kidneys are filtering out never actually touches the delicate tissue of the organ holding it.
Exactly. But in bladder pain syndrome, the research suggests that this gag layer is defective. That mucin coating gets scratched off, basically, creating what researchers call a leaky urothelium.
And once that barrier is breached, the acidic urine is just frying the raw tissue underneath.
Yes. And the specific culprit in that urine is potassium.
Potassium.
Yeah, potassium is a highly reactive ion, and urine is full of it. When that gag layer breaks down, potassium leaps through the urothelium and penetrates the deeper layers of the bladder wall.
Which sounds painful.
It initiates a catastrophic biological cascade. First, it causes immediate localized tissue injury. Then it triggers the mast cells.
And mast cells are basically the immune system's border patrol, right?
Exactly. When they detect the potassium, they degranulate, they literally burst open, flooding the tissue with histamine.
Which causes intense vasodilation, swelling, and more inflammation.
Right. But the histamine is just part of the problem. That leaked potassium also directly hits the sensory nerve endings sitting just below the surface, depolarizing them.
And that depolarization sends massive, unrelenting pain signals rocketing up the spinal cord to the brain.
Yeah. And the bladder muscle itself also reacts to this chemical burn. It violently contracts to expel the irritant, which is why the patient feels this sudden, overwhelming urgency to urinate, even if the bladder is virtually empty.
Because the central nervous system has essentially cranked the bladder's pain volume to a 10, the physical manifestations are just extreme.
You really are.
But here's where the biology expands beyond the pelvis. The sources highlight that BPS rarely operates in isolation. It's highly associated with a cluster of other unexplained systemic conditions.
Right, the sources call them the evil twins.
Yes, the evil twins, irritable bowel syndrome, fibromyalgia, endometriosis, and chronic fatigue syndrome.
It's a brutal combination.
So if someone has IBS, fibromyalgia, and BPS, you have to start wondering, is the bladder just the victim of a hyperactive alarm system? Like, is the central nervous system actually the instigator here?
The central nervous system is absolutely the common denominator here.
Yeah.
The literature shows that over 50% of people who develop BPS report experiencing chronic stress or trauma prior to onset.
Wait, really? Over 50%?
Yeah, but it's not just that stress causes flare-ups. The chronic pain of BPS actually remodels the physical architecture of the brain.
That is terrifying.
It is. When we look at functional MRI data, patients with chronic bladder pain syndrome show significant changes in the somatosensory gray matter volume in the brain.
So the brain is receiving this constant bladder on fire signal for months on end, and it physically recruits more neurons to process the pain.
Exactly.
It thickens the gray matter in that specific area. It learns to be in pain, permanently heightening systemic pain sensitivity.
And the clinical term for this is central sensitization. It creates a devastating phenomenon known as neurogenic inflammation.
Neurogenic inflammation. Okay, break that down for us.
Yeah, the communication between the brain and the body isn't a one-way street. Because the nervous system becomes chronically upregulated, the brain starts firing abnormal signals back down the pelvic nerves.
Oh, wow.
Yeah. These descending signals actually command the bladder tissue to release more mast cells and create more physical inflammation, even if the original irritant in the urine is gone.
So the brain's overreaction actually burns the bladder tissue, which then sends more pain signals back to the brain.
Exactly. It's a self-sustaining biological loop of misery.
That is just bleak. And because this condition is a tangled web of overlapping system failures, the defective JAG layer, the histamine cascade, and a rewired central nervous system, diagnosing it is an absolute labyrinth.
It's so difficult.
The clinical guidelines clearly state this is a diagnosis of exclusion.
And a diagnosis of exclusion is one of the most frustrating phrases in medicine. It means there is no definitive blood test, biomarker, or imaging scan that can positively confirm BPS. A clinician can only arrive at this diagnosis by exhaustively proving that you do not have anything else. They must rule out urinary tract infections, overactive bladder, sexually transmitted infections, radiation cystitis, kidney stones, and critically, bladder cancer.
I mean, if you've ever had a standard UTI, you know that sheer panic of needing to find a bathroom immediately.
Oh, yeah.
Now imagine having that feeling constantly and being forced to prove your innocence in a medical court by personally tracking down and eliminating every other possible suspect first, all while dealing with debilitating symptoms.
It's a nightmare for patients.
And the symptom metrics in these guidelines are just astonishing.
They are. The hallmark presentation includes intense suprapubic or pelvic pain, alongside severe urgency and frequency. To put this in perspective, a healthy voiding frequency is perhaps 6 to 8 times over a 24-hour period.
Okay, 6 to 8 times.
Right. But patients presenting with severe BPS might void anywhere from 16 to 40 times a day.
40 times a day. That means you are literally chained to a toilet.
Yeah, you are.
You are waking up every 20 or 30 minutes through the night. You are never entering deep, restorative sleep, which only further breaks down your immune system and your psychological resilience.
And the tragic part is, they aren't urinating because their bladder is actually full.
They aren't?
No. They're doing it as a desperate defense mechanism to ease the neurological burning of the organ stretching. Voiding keeps the bladder walls collapsed, which temporarily relieves the pressure on those inflamed nerve endings.
That makes total sense, but it sounds exhausting.
It is. But the clinical debate on how to officially define these symptoms is surprisingly fractured. The international guidelines actually don't align.
Really? Where do they disagree?
Well, the American Urological Association, the AUA, states that these symptoms must be present for 6 weeks to meet the diagnostic criteria. However, the European Society for the Study of BPS, or ESIC, dictates that symptoms must persist for 6 months.
Why is there such a massive discrepancy? 6 weeks versus 6 months is an eternity when you're running to the bathroom 40 times a day. What is the clinical debate driving that difference?
The European guidelines take a more conservative approach because they want to definitively rule out transient acute issues,
Like what?
like a severely bruised bladder from pelvic trauma or a particularly stubborn but localized infection that might take a few months to fully resolve. ESIC wants to ensure they aren't labeling a temporary issue as a chronic, incurable syndrome.
Okay, I guess that makes sense. And the Americans?
The American guidelines prioritize the neurology we just discussed. The AUA argues that if you wait 6 months, you give the brain too much time to undergo central sensitization.
Oh, wait.
They want to intervene at 6 weeks to try and stop the somatosensory gray matter from permanently rewiring itself.
That is fascinating. That actually makes perfect sense, but it highlights just how much guesswork is still involved. So how do they finally confirm what they're looking at? If the urine tests are clean, they usually move to a physical inspection, right?
Yes. The gold standard physical investigation is a cystoscopy with hydrodistension.
Okay, what does that involve?
The patient is placed under general anesthesia, and a urologist inserts a camera into the bladder. They then fill the bladder with water, stretching it far beyond its normal, comfortable capacity.
Which they have to do under anesthesia, because doing that to a conscious patient with a highly sensitized, inflamed bladder would cause unendurable agony.
Absolutely. Once the bladder is maximally distended and then drained, the urologist examines the mucosal wall. In a significant number of BPS patients, they will observe glomerulations.
Glomerulations.
Yeah, they are pinpoint petechial hemorrhages. Because the urothelium is so fragile and inflamed, the simple act of stretching it causes the tissue to weep tiny, distinct drops of blood.
Oh, wow.
And in that small subset of patients, this is also where they might finally identify those severe Hunner's lesions.
But even after navigating this entire maze, there's a massive trapdoor that doctors have to avoid. Our sources, particularly the gynecological reports, emphasize a crucial differential diagnosis called GSM.
Yes, genitourinary syndrome of menopause.
Right. How do doctors ensure they aren't missing a basic hormone deficiency and mistaking it for this complex neurological syndrome?
This is perhaps one of the most critical public health takeaways from the literature. GSM is incredibly common, affecting over 50% of postmenopausal women, yet it remains widely underdiagnosed.
Why is estrogen so important for the bladder?
Well, estrogen is not just a reproductive hormone. It is vital for maintaining the structural integrity of the pelvic floor. It keeps the tissues of the vagina, urethra, and bladder plump, moist, and elastic.
Okay.
It also maintains the glycogen levels in the tissue, which feed the healthy lactobacilli bacteria that keep the urinary tract acidic and ward off infections.
So when a woman enters menopause and her estrogen levels plummet, those tissues are starved. They literally thin out, lose their elasticity, and dry up.
Exactly. The clinical term is vulvovaginal atrophy. When that protective mucosal barrier breaks down and the tissue loses its blood supply, it perfectly mimics the presentation of bladder pain syndrome.
So you see the severe urgency, frequency, burning pain, and a vulnerability to recurrent UTIs.
Yes. And if a clinician doesn't recognize GSM, they might diagnose a postmenopausal woman with BPS and start prescribing heavy nerve medications or suggesting invasive procedures.
When her primary issue is just a localized hormone deficiency.
Precisely.
And the treatment for GSM is remarkably straightforward compared to BPS, right? The sources note that applying localized vaginal estrogen, like a Vagifem tablet or an estering ring, restores the blood flow.
Yeah, it reverses the cell atrophy and plumps the tissue back up without significantly raising systemic estrogen levels.
It's a vital first step to rule out. But okay, let's say you've run the gauntlet. You've ruled out cancer, you've ruled out infections, and it definitely isn't a lack of estrogen. You are left with a diagnosis of bladder pain syndrome. How on earth does modern medicine treat a condition when the underlying root cause is still essentially a mystery?
Well, because the etiology is unknown and clearly involves multiple overlapping systems, the clinical guidelines recommend a highly structured stepwise approach.
Like an escalator of treatments.
Exactly. You start with the least invasive, lowest risk options and systematically escalate the battle against the body's failures.
Step one seems to be all about tweaking the environment so the bladder has a chance to calm down. Diet modification is a huge pillar here. Patients are advised to ruthlessly eliminate coffee, alcohol, citrus, tomatoes, artificial sweeteners, and chocolate.
Which is basically everything fun.
Right. But why those specific foods? It's because they either acidify the urine or contain specific compounds that bypass the digestive breakdown and end up sitting in the bladder, constantly irritating that leaky gag layer we talked about earlier.
Yeah, by neutralizing the urine, you remove the chemical trigger. The other major component of this first step is physical therapy, but specifically targeted at the pelvic floor.
How does that help the bladder itself?
Well, when a patient is in constant radiating pelvic pain, their muscles react by involuntarily clenching. Over months and years, this leads to severe hypertonicity. The pelvic floor muscles are locked in a permanent, painful spasm.
Ah, I see.
So, pelvic floor myofascial release, performed by a specialized physical therapist, physically breaks that tension pain cycle.
But if avoiding tomatoes and doing specialized physical therapy doesn't stop the pain, we have to actively suppress the body's internal alarms. That brings us to step two, oral medications.
And this is where you really see doctors trying to hack those overlapping systems.
Yeah, they frequently prescribe amitriptyline. Now, that is a tricyclic antidepressant, but they aren't prescribing it because they think the patient is just depressed about their pain.
No, the psychiatric application is completely secondary here. In BPS, amitriptyline is prescribed at much lower doses for its specific neuropathic pain-blocking properties.
Okay, how does it work?
It works by inhibiting the reuptake of serotonin and norepinephrine in the descending pain pathways of the central nervous system. Essentially, it helps dampen that upregulated neurogenic inflammation loop we discussed.
So it turns down the volume of the nerves.
Exactly. And alongside that, they will often prescribe antihistamines, like hydroxyzine or cimetidine, to directly target those immune border patrols. The goal is to chemically force the mast cells in the bladder to stop degranulating and flooding the tissue with histamine.
And then there is a highly specific drug called pentosan polysulfate, known by the brand name Elmeron. The pharmacological goal of this drug is kind of brilliant, honestly.
It is. It's designed to act as an exogenous J-glare.
Right. It's essentially a synthetic replacement that you swallow, which then gets excreted into the urine to patch up the broken protective coating in the bladder. But the sources note a terrifying risk.
Yes, the retinal damage.
Long-term use can cause permanent pigmentary maculopathy, which is severe retinal damage in the eyes. The fact that patients are willing to risk their vision just to calm their bladder shows exactly how desperate the search for relief is.
It completely underscores the severity of the quality of life impact.
So if the oral medications fail or the side effects are just intolerable, the guidelines escalate to step 3, which is intravesical instillations.
Right. This involves bypassing the digestive and systemic circulation entirely. A catheter is inserted directly through the urethra, and liquid medication is pushed straight into the bladder cavity.
It's the biological equivalent of putting a fresh coat of waterproof paint on the inside of a leaky house. You are painting the walls directly.
That's exactly the right concept. Clinicians might instill heparin or hyaluronic acid, attempting to temporarily reconstruct that mucosal barrier right at the source.
And there's one FDA-approved drug for this, right?
Yes, the only FDA-approved installation for this specific condition is DMSO, or dimethyl sulfoxide.
What does that do?
It acts as a potent solvent, an anti-inflammatory, and a muscle relaxant, penetrating deeply into the bladder wall. Though I should note, it can cause a significant initial flare-up of pain before providing relief.
But if the waterproof paint just washes away, we arrive at step 4, the advanced, highly invasive therapies. And this is where the treatments start to sound almost like science fiction.
They really do.
Neuromodulation. Specifically, percutaneous tibial nerve stimulation, or PTNS. Our sources describe a procedure where doctors insert a fine needle into the patient's ankle and send an electrical pulse through it.
Wait, I have to ask, how does shocking someone's ankle do anything to fix a bleeding bladder?
I know, it sounds completely disconnected until you look at the neural wiring of the human body.
Okay, connect it for me.
The tibial nerve, which runs down the leg and into the ankle, originates from the exact same sacral nerve plexus, specifically the S2 through S4 nerve roots that controls the bladder and the pelvic floor.
Oh, wow.
So by stimulating the tibial nerve at the ankle, you are sending a retrograde electrical signal back up the leg into the spinal switchboard to try and manually reboot that hyperactive neurological loop.
It's like resetting a frozen computer by finding a backdoor in the hardware wiring.
But if even that fails to break the cycle, doctors might inject Botox directly into the detrusor muscle of the bladder to forcefully paralyze the spasms. They might use powerful systemic immunosuppressants like cyclosporine A to shut down the body's inflammatory response.
And finally, in the most intractable cases, they resort to major surgery.
Like physically removing the bladder altogether.
Yes, or augmenting it with intestinal tissue.
When you look at this entire escalator of interventions, from antihistamines to ankle shocks to organ removal, what is the ultimate takeaway for the medical community here?
Well, the inescapable conclusion drawn from this chaotic variety of treatments is that bladder pain syndrome is not a single disease.
It's not.
No. It is an umbrella term, a symptom cluster representing several distinct underlying pathological subtypes that we simply do not possess the technology to separate yet.
Ah, I see.
A treatment that miraculously cures a patient whose primary driver is an autoimmune sensus lesion will do absolutely nothing for a patient whose primary driver is central nervous system sensitization and pelvic floor hypertonicity.
Because they're effectively suffering from two different mechanical failures.
Right. But currently, we are lumping them all into the same diagnostic bucket, purely because they share the end-stage symptom of pelvic pain.
It really is a devastating multi-system failure. We've traced its journey from being dismissed as a facial tic in the 1800s to being mislabeled and mistreated as a standard bacterial infection for a century, to finally being recognized as a complex syndrome where the bladder, the central nervous system, and the immune system are basically locked in a civil war.
It requires highly personalized trial-and-error medicine.
And above all, it requires incredible endurance from the patients, who were often forced to become their own medical advocates while navigating severe sleep deprivation and systemic pain.
Absolutely.
And even if you never experience a single symptom of BPS, understanding this condition forces you to appreciate the deeply connected relationship between the environment of your body, the stress processing in your brain, and localized physical pain.
It completely shatters the illusion that our organs operate in isolation.
It really does. The mind and the body are inextricably linked, bound together by the nervous and immune systems, and BPS is perhaps one of the most vivid illustrations of that reality in modern medicine.
Totally agree.
But before we wrap up this deep dive, there is one final unexplored piece of the puzzle buried in the urology journals that we have to talk about. A wild card that might just hold the key to understanding this entire biological mystery.
Oh, right.
The sources document a phenomenon known in emergency rooms as ketamine bladder.
It is a fascinating and tragic toxicological mirror. Heavy recreational use of the psychoactive drug ketamine induces a severe, visually identical form of cystitis in users.
Because the metabolites of ketamine are excreted through the urine, right? And they are incredibly caustic.
Extremely caustic, yes.
When they hit the bladder, they instantly induce the exact same urothelial destruction, the exact same breakdown of the JAG layer, and the exact same nerve upregulation that takes years to develop in BPS.
And tragically, this damage doesn't always reverse when the user stops taking the drug.
It leaves you with a really provocative thought. If a single chemical compound can so perfectly mimic the exact mechanism of this centuries-old medical mystery, could the key to finally curing BPS be hiding right there, inside the toxicology of a party drug? If researchers can figure out exactly how ketamine breaks the biological machine, maybe they can finally figure out how to put it back together. Something to mull over until the next deep dive.